Hello and welcome to my discussion on renal. I hope you're ready, had your drink, gone to the washroom, and fully devoted to studying renal today with me. So, if you're studying this, that means that you are close to your exams and want to get as much information in this area as possible. So, fret not, we're here to help, and my name is Swati. So, I'll be your host today. What you're seeing right in front of you is a chapter I've taken from the book First Aid, very common, very popular, and very good for you right now, fellow human. Don't worry, I'll walk through it because it's very heavy, very intense, and but what it has is information that you will be needing in your exam, and it will help for sure. There are going to be points that I'll miss, so I want you to be fully conscious and fully cooperative. So make those points yourself when you get the time next. Okay, I know you've got this book, so I'm going to skip all the embryology wala section because it's just too much. Let's come to the anatomy first of all, okay? So renal anatomy, yeah, there's not much newness into this. Remember the first thing that you know all of this, okay? You've read this so many times, you've regurgitated it in your exams, and now it's all gonna come back, okay? So don't worry, we are gonna get through this. And the way we are going to do this is you can read this all by yourself, there's no issue, but the important thing is revising it, okay? Whatever comes to your head, just let it come and jot down whatever you are remembering and revising on the side, okay? I'm going to be missing most of the points also, so don't rely on me fully. You've got this, you know? Okay, coming to the renal arteries and veins. First of all, we have the aorta, through which we have the two renal arteries popping out like this. So look at this kidney, we have the renal artery going in. This is important because now it divides, and how it divides also we must know. So first of all, it divides into this segmental artery. It goes up here, up there, and down here. I don't know if you can see the pointer. And then the segmental artery then further divides into interlobar arteries. Look at this. These are lobes, right? So they are going interlobarly as arteries. So these are interlobar arteries. Next, we are going to make this arcade, like a mall, a shopping mall with a lot of channels. So that's why you get the arcuate arteries, where they all like come together and they are over here like this, and then they go into even further dissection into tiny shops of the mall. These are called interlobular arteries, you know, like little passages, little washrooms inside the individual mall shops. And that's exactly how the veins are also. You know, if you just do the opposite at the shop water system, this is the tiny space between the shops. These are called the interlobular veins. Then remember, you're gonna tell me what the rest is. Yep, this is the arcuate vein. Coming back outside between the lobes is the interlobar vein. Then you have the segmental. No, there's no segmental vein here. It just goes immediately into the renal vein. There's no segmental vein. Haha. Right. So now we've come to the interlobular artery. This one. Okay, it further divides because now we're going to pierce individual nephrons. As you can see, this is the individual nephron. It's going to go into the Bowman's capsule, where it's going to make a capillary network. Okay. The reason we do this is to create a lot of surface areas through which you've done this. Okay, 12th, 11th, I don't even know, your studies were way better than mine, so all of this must be coming back right now. Okay, yeah, so we've got to create a lot of surface area so that so much of it's like, you know, 20 to 25% of your blood is going into your kidneys. So this part is crucial. Now this is where the filtration happens, that means your waste things are going to go out into this yellow space. This is the Bowman's capsule, yeah. So how it's going to do that, we're going to come back again later. So yeah, and then it goes in through the afferent arteriole, comes out to the efferent arteriole. And how we can measure, like, this is how we control the amount of blood and the amount of filtration that is happening, because if we do constriction or dilatation of these arteries, you get a difference in the filtration factors. We're going to come back to that afterwards. Like, for example, NSAIDs and ACE inhibitors are a major example. Okay, even this part of the renal artery, if it gets squeezed, or if there's stenosis, it can have a major impact, because once there's a stenosis of this, then this kidney is going to suffer, isn't it? And then there are a number of ways why this would happen, and the renal system is very much responsible for causing hypertension, right? This is the secondary cause of hypertension. So it's all crucial. Look how twisted it all is coming together, and then it comes out again in a vein system, comes back to renal vein and goes out again into the internal into the IVC. Okay. Oh, look, it says here, left renal vein receives 2 additional veins. The left side receives 2 additional veins, which is the left suprarenal and the left gonadal vein. So the left side vein is longer, because the IVC is on the right side, right? So it's going to be longer, and to prevent any complexity in our system, so the suprarenal, the one that produces hormones, what is called adrenal gland, is just like, bro, I'm too lazy to go all the way over there. I'll just give my supply to you, and then you can supply through yourself to the IVC. The same with the gonadal veins, right? It makes sense. Renal medulla, which is this part, receives significantly less blood flow than the renal cortex, and you can see why, because all of this structure is in the cortex, right? This part, this area is in the cortex, whereas this should be in the medulla. This makes medulla very sensitive to hypoxia and vulnerable to ischemic damage. Interesting. Left kidney is taken during living donor transplantation because it has a longer renal vein, as I said. So but it is fixed into the right side of the patient. So you've taken the left kidney and you put it on the right, the ischial area. And remember, when that happens, you do not take out the other kidneys that are not functioning. It is just put as an extra organ. Glomerular anatomy. Now we're coming to this area with this big heavy stuff. Okay, so we got the afferent arteriole, that one's coming from upstairs now, like this. It's creating channel, building a whole lot of friends here, depositing its stuff, and then the blood is coming back out again. And now you can see there's a lot of now you can see the barrier also. There's a lot of cells also involved in this area. So artery going in, blood going in, the first thing it sees before it escapes the filter that is going to happen is, the first thing it's going to see is this cell here. This is the endothelial cell of the lining of the vessel, right? Because it needs to go through that in order to escape. This is waste stuff that is escaping. The next structure would be the basement membrane right here. And remember, this is a type 4 collagen basement membrane. I just remember that because I just read this chapter 2 minutes ago. So don't worry about it. Coming back to your biochemistry, there are, is it 4 or 5 collagens? I'll leave that to you. So this is type 4 collagen, and then it again has to go through even further into this space. This is called the Bowman space, and it has to go through this cell structure, which is called a podocyte. A podocyte is basically epithelial lining, but it's a cell that looks like feet, and this is the only thing that is damaged in minimal change disease, which is seen in children. It's one of the nephrotic syndromes. We'll study about it later. But yeah, this structure is the only thing that's damaged, and it doesn't do anything else. There's no deposit or anything, and we'll come to it. Also, you can see mesangial cells. These cells, they are providing like the bulk, in the system. You have the juxtaglomerular cells here, and then you have so this is going into the proximal convoluted tubule. This is then going further into the distal convoluted tubule. So in that distal convoluted tubule, you have macular denser cells. All of this is important because these cells control the laxity, or it controls the constriction of the vessels, which lead to how much filtration or how tense your arteries are going to be. Bowman's capsule, parietal layer, Bowman's endothelial cells. Yeah, we covered all this. Moving on, the course of the ureters. This is a good thing because when you have a surgery, you need to know, because you can and that's it. You're gonna have urine inside your pelvis, and it ain't pretty. Okay, so the first thing, the ureter comes out from the renal pelvis right here. Okay, and this is a special dye that they've injected that shows us the pathway into the bladder right here. So it rises from the renal pelvis under the gonadal arteries. We studied the gonadal vein, the left side. It was depositing directly into the renal vein. So the gonadal artery, it goes under the artery, but then it goes over the common iliac artery. The common iliac artery is arising from the aorta dividing into two. Yeah, so the renal ureter is going over that division. Then it goes again under the uterine artery, or the vas deferens in males, and it's going now away from the peritoneal cavity, and now it's coming into the bladder here. So uterine artery, you can see like part of it, or the vas deferens in males. So this is going below or behind these structures. Okay. Oh, and here is what I was saying: gynecological procedures like ligation of uterine or ovarian vessels may damage ureter, causing ureteral obstruction or leakage. So that is one of the post-renal failures. Post-renal failures. Yeah, you got pre-renal, renal, and post-renal. So post-renal occurs because some kind of obstruction is there, like a stone, like bladder outlet obstruction, like a tumor, or somebody just like closed and clamped down the ureter instead of the vessel. It's a major no-no. Bladder contraction compresses the intramural ureter, preventing urine reflux. Yeah, so that acts like a physiological valve. When bladder contracts this area spontaneously, it also causes the compresses the ureter, so the urine backflow doesn't occur. Gosh. Blood supply to ureter. Proximally over here, you got the renal arteries, which is because it's part of the renal system, right? It's just there, so why not? You got the renal arteries going through the pelvis area, so we're just going to supply that area. The middle part, just gonadal artery, aorta. So this is where it's going over the common iliac artery, right? So it's common that part, though, that artery will also supply the ureter, right? So common and internal iliac arteries, aorta, gonadal arteries. Then distal part, which is the internal iliac and superior vesical artery. Superior vesical is supplying the bladder, and internal iliac we studied. So yeah, that's what is gonna happen. I'm just gonna quickly read this because I'm so tired now. Water flows over the iliacs and under the bridge. This is a nice mnemonic. So it asks, what are the 3 points of ureteral obstruction? First was the uretero-pelvic junction, where it's just coming out, then the pelvic inlet, and then this part where it's going into the bladder, uretero-vesical junction. These are the point of obstructions. Fluid compartments, you will need to know this because most of our body is composed of this, right? There's fluids in the whole of the body. So how much it was inside the cell, how much is outside, how much is inside the vessels, it helps to know, because then we can balance it when there's some kind of a damage or derangement. Yeah, you remember learning about anion gaps, or if you remember learning about, yeah, all of that is just deadly. I know, but yeah, we'll get there. It also helps us to know how much fluid we need to give this patient, which kind of fluid. It helps the patient the most. Is it Ringer lactate? Is it normal saline? Is it Hartmann solution? All of these compositions are there, so they help. This guy is a 70 kg man. Yeah, so that's a heavy man or a woman, depending on who you are. It's is divided into total body water. So we're not including the mass here. Remember, I think 60 to 70% of your body is composed of water. So it's actually saying 60% of body mass is water, and then it's further divided into interstitial fluid, the plasma. This is the intracellular fluid, and then extracellular fluid, and you can see the majority is intracellular fluid, which contains about 40% of the 70 kg man. So 40% is actually inside the cells, which is not visible. And that's why when you're going in a diet where they give you protein, it makes you lose water. So this is how you lose weight. That's why don't go to diets, guys. Just exercise and control your meals. Extracellularly is about 20% of the 70 kg, and this is constituting of plasma and interstitial fluid. So this is interstitial fluid is anything between the cells, not inside the cell. Between the cells is kind of helping with the structuring of the thing. Plasma is the liquid part of the blood, whereas this you have the rest of it as this cells, which would be intracellular, obviously. You can see here about 2.8 liters is RBC volume and 3.5 liters is plasma. So actually your blood is about 5 liters. 3, 4, 5. So this is actually 6 liters here. Yeah, but yeah, almost close. About 20% of that goes to your kidneys, 25% is in your head at the same time, and the rest. So you can measure this blood by HCT. Okay, we'll come to that here. Yeah, so this is important because what is inside the cell, what is outside the cell? Electrolytes. Your majority of the electrolytes, potassium, should be inside the cell, and majority of sodium should be outside the cell. That's why when you're measuring your blood electrolytes, sodium should be about 135 to 150, and outside the cell, potassium should be low, so 3.5 to 5.5. Whereas if you're measuring the potassium inside or sodium inside, wouldn't be opposite? Maybe. As you can see, 40% of intracellular contains potassium, magnesium, and all these phosphates like ATP, which you need for energy, and even ribose and things like that. Yeah. Then outside the cell, extracellular fluid, you got the sodium, you got the chloride, bicarbonates, and albumin. So how you measure the plasma volume here is you measure the albumin in it, and you do that radio labeling the albumin. Extracellular volume can be measured by inulin or mannitol. Inulin, we'll come to it, is it divides. You use inulin as a GFR measuring tool. It's a dye or something that's injected in your blood, and it doesn't get absorbed, it doesn't get secreted inside your cells. So whatever is injected, it comes out through your pee, all of it. So that's how you can measure your GFR. Mannitol is a medicine you used to give, which can cause osmotic diarrhea, or it can cause, well, not diarrhea because it gets absorbed, but it causes this, if it's given in, it helps to reduce your intra cerebral volume, because it causes, well, it removes the water from there. Yeah, so it helps that way. Osmolality should be between 275 to 295 milliosmoles per kg H2O. And we know there are some things that have this increase, the serum osmolality increases, and something that decreases in, I may get this wrong, so bear in mind, it decreases in so osmolality is basically like the sodium amount in your blood. Okay, it decreases in when you have low sodium but normal amount of water, like a syndrome called SIADH. We'll talk about it ahead. It increases when you have dehydration, things like that. Plasma volume. So plasma volume, hello, it can be measured. This is the whole bottle, like, so total blood volume, all of this multiplied by 1 minus HCT, so this much multiplied by TBV. This is the plasma volume. I hope you're with me so far. We have hardly covered anything, but at least we've covered almost 2 pages. And yeah, so there's a lot of information here. You have these things that you want to know, like this. I'm gonna highlight it a different color. I'm gonna do pink. Plasma volume is TBV times, yeah, because I'm not gonna remember this at all. These it's good to remember this because it saves time in the exam, so you're not riffling through your sheets to look at normal values. Always look at the units because they may be differing. For example, calcium units are given different in different books depending on if they're UK or US based or Indian. So yeah, it can really put you off. Blood is just everything cellular is inside the HCT, whereas all the water remaining is the rest, plasma. Now what this section, so blood is actually composed of cells. Now how do our cells not get filtered, as in why don't they appear in our pee? Because even since we have all this saman, all these things going inside the Bowman's capsule into the urine generating machine, it's because of the size of these cells, the space between them. For example, the epithelial, the podocytes, and the basement membrane, the size, the gap between them, it has a particular figure, less than 100 nanometers. I read it. So yeah, anything above that will not go inside, will not go through, will just come back out into the efferent arterioles. That's one. Second, everything here, the Bowman's capsule, inside that, this area is negatively charged. What that means is if you are negative and you come across other things that are negative, you're gonna be repelled. You're gonna want to get out of there. If you are positive, for example, and still you are large, larger than the gap, you will still not be able to go through. So only things that are small and negative can seep through. Okay, and how negative or how small, let's find out. Okay, so glomerular filtration barrier, you have the endothelial cell pore, this is the blood here, then the glomerular basement membrane here, like these things, and the podocytes are these food processes. It's composed of the endothelium, type 4 collagen chains, and heparin sulfate, and the visceral epithelial layer consisting of podocyte food processes. So these are the cause. Charger barrier. So glomerular filtration barrier contains negatively charged glycoproteins that prevent entry of negatively charged molecules like albumin. So albumin does not seep through. That's why if people have microalbuminuria in their urine, like fresh morning sample in diabetes, if you have microalbuminuria, that means you have small amount of albumin, less than 300 in your urine. That's bad because it's showing that something is not right and your kidneys are getting damaged. If you have albuminuria, that's even worse. Microalbuminuria can be stopped and reversed, so better control those sugars. Size barrier, we can look at the size between them. So endothelium, less than 100 nanometers, can also only seep through, whereas so these food processes, it's saying they and the glomerular membrane are interposed, as in they're like this. So the gap between these are even smaller. They're like slit diaphragms. So only less than 40 to 50 nanometer molecules can seep through with a negative charge. Sorry, with a positive charge. I just messed that up. All of this stuff you're gonna have to remember, it's maths, and guys, I'm not good at maths, so this stuff you're gonna have to write a lot of it, but I'll go through it as quickly as I can. You know, the renal clearance, yeah, it's not nice having to read this, but all of it comes in the exam in the end, and what you're gonna do is you're gonna revise it as much as possible, because if you don't, then it's still gonna go out of your head. Renal clearance is the volume of plasma from which the volume of plasma, so that of a substance that is cleared at a particular time. So we're looking at a particular substance called substance X, and how much of it is cleared in a particular given time, like 1 minute. Yeah. Anyway, back to our studies. We're gonna finish this chapter no matter what. You are going to learn this, dear. Okay? Whether it takes me 2 days, 3 days, you're gonna learn this. And I'm not gonna stop until you do. Okay? We're gonna revise the shit out of this page. So, renal clearance, we studied substance X. It said completely cleared in the urine. Completely. Yeah, so if this substance, well, okay, here it is. Urine concentration of X. Okay, so we're looking at, for example, beetroot. You know, you can see beetroot in our urine. Yeah. Oh, don't feel good. Oh no, something's not right. Oh no, substance that is cleared is less than that amount that is filtered, obviously that means it's not fully filtered, yeah, or there is some kind of reabsorption. That means the amount of all of it is getting filtered, but some of it is being brought back in, into the body, so that is when your substance is less than GFR. If substance is more than GFR, which means that you have that substance, but more of it is being filtered than it is actually present, that means that it is also secreted in the tubules. And if it's the same, there is no net secretion or reabsorption. That means it's freely flowing. What is GFR? So that's why we look at X as inulin, because you can't secrete it, you can't reabsorb it. So everything that inulin is, it just goes into your urine. Same with creatinine. We use creatinine because it's kind of similar, but it slightly overestimates GFR because it's slightly secreted in your proximal tubules. But it's close approximation, because inulin you have to inject, whereas creatinine is present in your body. It's coming out from your muscles. And that's the formula here that they've given, inulin equals GFR. So that how can you calculate GFR of inulin is the amount of inulin in your urine multiplied by your flow rate of your urine divided by the plasma volume of inulin. Oh, look at this next. This don't make sense though. Dog. The filtration coefficient times your, pay close attention to this, the glomerular capillary hydrostatic pressure. Okay, so this is the pressure that is being pushing the water pressure pushing to get out of here, minus the Bowman space hydrostatic pressure. And I read somewhere that is supposed to be, oh yeah, so you have hydrostatic pressure, okay, minus the oncotic pressure of the negative of the difference of the glomerular capillaries and the Bowman space. Yeah. Okay. Why are they giving it here? Because they're gonna give it again later on. When we look down, they're gonna give it again. Somewhere. Be prepared. And it's not pretty. So I'll leave it to you to sort out. I want to talk about how this is the renal blood flow order regulation, and actually your kidneys and your body is so awesome, because it knows how to sort itself out if we don't mess it up. Order regulatory mechanisms help maintain a constant blood flow and GFR to protect the kidney from rapid increases or decreases in renal perfusion pressure that cause renal injury or decrease glomerular filtration. itself. The tubuloglomerular, this is where your RAS system comes in. So it senses the macular denser cells that were in the distal convoluted tubule. They sense the sodium, potassium, or tonicity of the filtrate. If it's high, then it sends a signal to the paracrine glands, and the hormone that is responsible here is a mineralocorticoid by the name of, begins with A, aldosterone. Yes, that would again decrease the renal blood flow because they would cause vasoconstriction. I said that wrong because it would renal plasma flow effectiveness. Here we go again. This is another of those shits that we have to know. So this is the item that they use, not inulin this time, inside to check this volume. They use something called a para-amino hypuric acid. Yes. So how much of this is cleared? That's how we can know. Because all of it is present in the kidney. Some of it is filtered, like here, and some of it is secreted, like here. The majority is secreted. So that's how we can know effective renal plasma flow. Why didn't they use GFR, I wonder? Why didn't they use inulin? Because that is specific to just filtration. Whereas you want to know secretion also here. So renal plasma flow. I think, don't take my words for it, guys. Remember this one? We did 1 minus HCD when we were talking about total blood. Look at this, total blood volume multiplied by 1 minus HCD is the plasma volume. We're gonna use the same equation now again. So if it's talking about total blood flow, but no, we're talking about renal specific to one organ now. Instead of the whole blood flow, we're talking about renal blood flow. So if we were talking about renal plasma flow, like this, renal plasma volume, renal plasma flow is equal to renal blood flow multiplied by 1 minus HCD reversed. So it's the same equation here. 1 minus HCD, then divide that by renal plasma, you'll get the renal blood flow. It's shit, but we've gotta know this. So it's not shit, it's good. Important. You have the effective renal plasma flow, which is the same equation that we did. It's also clearance of PAH. Yeah. So renal plasma flow underestimates true renal plasma flow slightly. is filtration happening, whereas filtration fraction is how much of this blood is getting inside this area. So it depends on renal plasma flow as well. For example, if renal plasma flow, this is renal plasma flow, if it increases, then filtration fraction, you got more plasma flow here. But in that way, filtration GFR should also increase, to be honest, if that was the case. But we'll find out now. Okay, so the filtration fraction would actually be the same because it's a ratio of these two. Filtered load is the GFR multiplied by plasma concentration. Okay. Now my favorite part, how and what happens when they give medicine. For example, you have this macula densa. What it does, it detects the amount of constriction or the pressure, and then it sends a signal to the juxtaglomerulus cell, which produces renin here, right? And then it goes into the RAS system. Now, what happens is, what happens is prostaglandins naturally, no medicine now, they dilate the afferent arteriole. So afferent arteriole would be dilated. That would cause more blood to go inside the Bowman's capsule, right? So that would actually increase the plasma flow into the Bowman's capsule. But that would also cause an increased GFR. Now, the amount of blood is going inside here. All of that is also going into the amount of increasing the rate of this filtration also. So in technicality, there's not much difference in the filtration fraction because it's gonna be the same. Whereas, for example, if angiotensin 2 constricts the efferent arteriole, so angiotensin 2 would block this part or constrict, lessen this. So renal plasma flow should lessen here because there's a blockage ahead up, right? So you got a stagnation in blood because of the efferent arteriole being compressed, and that's why you have more time for filtration to occur, right? So filtration would happen more, glomerular filtration rate would increase, but renal plasma flow is actually less. So looking back into the equation, and that kind of makes sense because more of filtration fraction is happening now. And the examples these examples are given by medicines. Like if you don't want this constriction to happen, dilation, these medicines are called NSAIDs. What they do is you have a lot of patients who are taking ibuprofen or other medicines like aspirin. So what they do is they counteract the action of this afferent arterial dilatation, so you don't get this dilatation. And that's why they have a different way of working. Now, if patients have ACE inhibitors, for example, ramipril, for their hypertension, what happens is that their efferent arterioles, they don't get constricted. So more of the plasma flow is happening, and therefore they have no restriction to these. is filtered, but 20% has come out and 80% is removed, excreted. So 100% minus 80%, you now know the reabsorption rate, secretion rate, what you are putting into that, tubular area where all the filtered area stuff is going. So you're adding on to the filtration, right? Or everything that is filtered, you're adding more into it. So you got a higher amount of excretion in the urine. So secretion rate is actually higher amount of excretion you have the urine in the urine that take away what you had in the filter. Okay, so let's calculate the fractional excretion of sodium, which is very common. You do calculate this, by the way, because it tells us if anything, you have to calculate this amount of sodium in your urine. It gives a lot of information about your hyponatremia in your blood. So what's the sodium that was excreted divided by the sodium that was filtered? Okay, so that's the fractional excretion of sodium. So this is the same formula, and you guys go ahead, do it yourself. Now coming on to glucose clearance. Glucose is smaller than 40 to 50 nanometers. That's why it's removed into the filter. But at only a certain amount, it gets put into the urine because it gets reabsorbed by the proximal tubule cells using this co-transporter, sodium glucose co-transporter. And this is what it looks like, sodium glucose co-transporter. This is a medicine. These medicines that inhibit this transporter, they actually cause increased glucose in your urine, which is dangerous because it can cause infections. Okay, this is the normal range of it. Glucose in your blood, 60 to 120. If by any chance your blood glucose goes above 200, that is when it starts appearing in your pee, because there is a threshold that is happening. For example, let's look at this graph, plasma glucose. Right, you have plasma glucose can be up to anything. Mine was here when I was diagnosed. It has even gone up to 600 at a point. Yes. So can you imagine that my glucose was most definitely high in my urine at that time? When it appears in your urine is at this stage. Why? Because up till this point it was getting reabsorbed fully. Yes, it was definitely getting filtered. That means it was appearing in your Bowman's capsule. It was appearing there, but it was also getting reabsorbed. But as soon as this threshold is hit, renal threshold, what that means is these things, SGLT2, co-transported 2, these are the things that reabsorb glucose. Now these are getting full. That means they're getting saturated, and now they cannot take any more. So what happens is they start glucose starts going out into the tubules now, and that's why it's getting removed in the urine. Before that, it was getting reabsorbed. It is at max at this level. Glucose transport at 375. It's at the threshold when it's fully saturated, and you can see. But this display means that not all of them are fully saturated at 375. They may be fully saturated even below that. At about 350 it starts happening here at 300. So it depends, but yeah, 200 is the renal threshold. And this is very important. So have you seen patients who are pregnant? Have you seen pregnant females? They actually have a lower threshold course.